Okay, it is 7:30, so welcome to Cardiology Going Rounds. I'm Jeannie Poole, and it is my pleasure to introduce Chinonso Opara today, who is our speaker. I've had the chance to get to know him because, of course, he's going to come to EP, which we're thrilled about, but also in other ways. Chinonso has spent a lot of time at the University of Washington. I think I sort of did that too through my training, mostly was at the University of Washington. But he did go to Vanderbilt for his medical school and then came back to the University of Washington where he did internal medicine, residency, cardiology, and then he's going to be doing EP. In addition to his formal training, he's received a number of important certificates, such as the Clinical Research Methods Certificate, and also he did the Global Health Summer Institute at the UW. He has many, many honors over his entire educational career. I'm only going to mention two of them. One is that he received the Mayo Clinic Cardiovascular Board Review Nishimura Scholar in 2023 and the University of Washington Cardiology Fellow Teaching Award in 2022. Reviewing his CV, it's clear that he has a passion to teach and to serve patients in health resource-constrained global and local areas. Dating back to 2011, he was involved in important activities such as the Initiative for Maximizing Student Diversity Scholar. And during his medicine residency, he spent his 3-year continuity clinic at Harborview's International Medicine Clinic. And in the past years, he's been working with Chris Longenecker on a number of projects focused on rheumatic heart disease in Uganda. And he has co-authored or been the senior author on 5 papers. One of them was published in my journal, Heart Rhythm Open Access journal recently, which we were really excited to have that paper. And if you want to see him on YouTube TV, Heart Rhythm Society, HRS TV, has a YouTube interview with Chinonso and Chris Longenecker. That paper was called Outcomes and Care Quality Metrics for People Living with Rheumatic Heart Disease and Atrial Fibrillation in Uganda. So I asked Chinonso what his ultimate goals are, and I just want to share those with you. So he said that his goals are to help contribute to sustainably expanding treatment and management of cardiovascular diseases and its precedence in Africa. He plans on doing this through specific community work in Nigeria, home country, and then for Africa in general, through contributing towards research and implementing initiatives that make cardiac services more available to people who need them. In Nigeria, he hopes to build off of the work he has done in the past with, is it called Aki Association USA? Mm-hmm. And that one, your family's been very involved in.
Yes.
Maybe you'll have a chance to tell us more about that. But that association helps to build out and sustain medical center and healthcare that brings affordable healthcare more proximate to where people in the community are actually living. So he also said, as a budding electrophysiologist, he hopes to contribute to the understanding of opportunities to expand arrhythmia care in Africa, and then help implement interventions to expand arrhythmia care in Africa. So this is great. It's a particular interest of mine through the journal called Global Voices. I was just telling Chinonso we had a wonderful Africa Summit at the Heart Rhythm Society where there were members that represented probably about 12 to 13 of the countries in Africa who discussed from their perspective sort of the state of the art of arrhythmia care in those countries. So thank you for being our speaker this morning. I'm going to turn it over to you now.
All right. Thank you, Dr. Poole, for that kind introduction. All right. Good morning. Can everyone hear me okay? All right. So I'm going to talk to you all today about rheumatic heart disease and cardiovascular capacity building in Africa. I have no pertinent disclosures. The objectives of my talk are to explore the epidemiology, clinical impact, and financial burden of rheumatic heart disease in Africa, summarize opportunities to address cardiovascular disease in Africa, and to appreciate ongoing efforts to expand cardiovascular capacity in Africa. To accomplish these objectives, I will first review a historical perspective in Africa, and we will review the scope of rheumatic heart disease, and we will go over some research projects I am involved in Uganda, and we will go over some research projects some community projects I am involved in Nigeria. So let's start in Kampala, the capital city of Uganda in East Africa. This picture is Mulago National Referral Hospital. It was established in 1913 and is a teaching hospital for Makerere University in Kampala, the capital of Uganda. In 1958, the cardiology clinic was started. Then soon after, in 1960, the first cardiac catheterization lab was built. And then in 1970, cardiac surgery capacity was started, primarily to help with congenital heart diseases in children. But however, the country's health infrastructure, much of the health infrastructure, did not hold up to the political turmoil of the 1970s and 1980s. And so this led to a reduction to much of the cardiac services that had been established over the prior decade. In 1981, the HIV virus became increasingly recognized across the world, particularly in African nations with limited health infrastructure. And in 1989, the Ugandan government invited Dr. Fred Robbins to help address the HIV epidemic in Uganda. Dr. Fred Robbins is pictured here, and he was one of the co-winners of the 1954 Nobel Prize in Physiology or Medicine for the work they contributed towards our understanding of the poliovirus. And over the next couple of decades, Dr. Robbins partnered with Case Western University and University Hospitals in Cleveland to establish strong relationships with the Ugandan government, Makerere University, Mulago Hospital, and the Joint Clinical Research Center. The Joint Clinical Research Center is a network of HIV clinics that is headquartered in Lubowa, about 10 kilometers from Kampala. A very important aspect of the HIV response, the public health response to HIV, was to decentralize the HIV care away from the central region of Uganda, especially as antiretroviral therapy started coming online in the early 90s. And so regional centers of excellence were established in the more rural regions of Uganda. And they were established in Lira and Gulu in the northern region, Mbale in the eastern region, Fort Portal, Mbarara, and Kabale in the western region. And ever since then, HIV care has continued to decentralize and is localized to where patients are closer. So the HIV care is localized to be more proximal to where patients live. And this was a very important response because it also helped to establish a precedence for chronic disease management in Uganda and laid down the infrastructure through which to do so. And around 2011, the relationship in Cleveland with university hospitals and Case Western expanded beyond non-communicable diseases to cardiovascular disease. And around this time, the Uganda Heart Institute, or UHI, which was reestablished in 1988, it had already been working since 2007 with Children's National Medical Center in Washington, D.C., to build pediatric congenital heart disease, to build out their ability to perform pediatric congenital heart disease operations. And so early on, the Uganda Heart Institute was a key partner in expanding the cardiovascular services in Uganda. And so it was a key early partner. And this picture shows the Uganda Heart Institute cath lab, which was built in 2012. And this shows a picture in April 2012 when the installation of the cath lab was completed. And 18 days later, the first diagnostic coronary angiogram was performed under Dr. Leonard Stango from South Africa on April 30th. And so throughout 2012 and 2013, much of the cardiac catheterization lab cases that were performed via skills transfer camps by external visiting teams. However, it became clear that these individual trips were not a sustainable strategy to expand cardiovascular capacity in Uganda. And so a more durable strategy had to be found. The first step was to identify an optimum disease model, and then to identify a solution that is both desirable to local stakeholders and is also feasible to implement. At the time, a disease model that made sense was rheumatic heart disease. So we know that rheumatic heart disease is caused by repeated bouts of rheumatic fever, which is caused by repeated bouts of group A strep infection. And rheumatic heart disease in its severe form can lead to heart failure, which can lead to premature disability and death. An important part of prevention of rheumatic heart disease is a reduction in transmission of group A strep, either through treatment with penicillin or with non-pharmaceutical forms of primordial prevention, such as social and economic development. So, for example, treatment with penicillin of streptococcal pharyngitis has been shown to have a 68% relative risk reduction in the progression to rheumatic fever. And amongst those who do have rheumatic fever, treatment with intramuscular penicillin has been shown to have a 16% relative risk reduction in repeated group A strep infection and a 55% relative risk reduction in recurrent rheumatic fever. So these are the results of the GO trial. The GO trial was looking at the effect of intramuscular penicillin on the progression of rheumatic heart disease, or RHD, among children living in northern Uganda who were diagnosed echocardiographically with rheumatic heart disease. Ultimately, they showed that after 2 years of follow-up, intramuscular penicillin was associated with a 90% relative risk reduction in the progression of rheumatic heart disease. And so this demonstrates the importance of intramuscular penicillin in the treatment of rheumatic heart disease. So we do have some episodes, we do have some example of good news. Over the last 30 plus years, the mortality burden worldwide from rheumatic heart disease has been going down. Similarly, if we look at disability-adjusted life years, which is a combination of disability and mortality, this burden also has been going down worldwide. However, some pieces of not so good news is that the reduction in mortality burden has not been evenly distributed worldwide, as we see that Africa and Southeast Asia have a disproportionate amount of mortality burden from rheumatic heart disease. And similarly, when we look at disability-adjusted life years, or the combination of disability and mortality, we see that this burden is primarily on Africa and Southeast Asia. And this is a really important point because rheumatic heart disease affects many young people. They would otherwise be young and healthy, but much of their productivity is cut short. And so rheumatic heart disease was an ideal starting point for cardiovascular care expansion in Uganda because it affects both children and adults and has broad and deep socioeconomic impacts. It is diagnosed clinically with echocardiography and requires chronic care coordination. And importantly, it requires percutaneous and surgical intervention when the disease is advanced. And the decision to focus on rheumatic heart disease was a serendipitous one, because around that time, the Medtronic Foundation and the World Heart Federation were looking for ways to address rheumatic heart disease burden worldwide, especially in endemic regions. And so in February 2013, university hospitals and Case Western Reserve University, along with Chris Longenecker, received a $1.3 million Medtronic Foundation grant specifically to leverage long-term partnerships and existing HIV/AIDS infrastructure to create a comprehensive RHD treatment program in Uganda. And in 2014, the Medtronic Foundation launched RHD Action to further deepen and expand these initiatives. And since then, additional funding and partners have been added to help address the burden of rheumatic heart disease in Uganda. And specifically, I would like to call out Craig Sable from Children's National Medical Center, David Watkins here from the University of Washington, and Andrea Beaton, who have also received strategically focused research network grants from the American Heart Association to address rheumatic heart disease in Uganda. And most recently, Andrea Beaton has received a grant from the Leduc Foundation to help with developing a diagnostic test for rheumatic fever. So focus group discussions were done with local stakeholders in order to have a better idea of methods through which to address rheumatic heart disease in Uganda. And insights gained from patients, the patients were saying that the distance to an RHD care facility was a significant barrier to receiving their penicillin prophylaxis. And the JCRC staff, the Joint Clinical Research Center staff who were providing HIV care, they noted a desire for more training, especially as they became relatively less busy as HIV care had localized. And so an important part of the RHD action was to expand the RHD infrastructure in Uganda. And so this was done by using the lattice work that had already been laid down by the precedents of the public health response to the HIV epidemic. And so we had mentioned that the Joint Clinical Research Center established regional centers of excellence in other regional medical centers outside of Uganda. And so RHD centers of excellence were also established outside of the central region. So they were established in Lira and Gulu in the northern region, in Mbarara in the western region, in Bale in the eastern region, and of course also in Luboa. We do understand that chronic care delivery requires a way to keep track of patients and their clinical outcomes. And particularly with rheumatic heart disease, it's important to keep track of adherence to penicillin. And so a web-based registry was designed to accomplish this objective. And also an RHD treatment cascade was adopted off of the HIV treatment cascade in order to better understand ways in which to address rheumatic heart disease in Uganda. And just like insight was received from patients and the JCRC staff, insight was also received from the physicians at UHI, Uganda Heart Institute. They said they wanted more advanced cath lab training so they could independently perform cath lab procedures on the Ugandan population. And so the relationships in Cleveland with university hospitals and Case Western were leveraged to allow UHI physicians to come there to learn more advanced cath lab procedures. And also relationships with partners in Brazil allowed UHI physicians to go to Brazil to learn percutaneous mitral balloon commissurotomy, which is a bread and butter procedure for severe mitral stenosis in rheumatic heart disease. And this picture shows Dr. Emi Okello at UHI, the cath lab, and Dr. Marco Costa from Brazil. They were performing the first ever percutaneous mitral balloon commissurotomy on a patient with severe mitral stenosis and RHD. This picture was taken in August 2012. And then 4 years later, in December 2016, the local UHI physicians were then able to complete their first percutaneous mitral balloon commissurotomy in that cath lab. And ever since, the number of cath lab cases that are done independently by UHI physicians has dramatically expanded and includes percutaneous coronary interventions, pacemakers, and ICDs. And this table demonstrates the financing procedures for pediatric cath lab cases and adult cath lab cases. 70% of the pediatric cases are financed through philanthropy, while 25% is financed through out-of-pocket. And this compares to almost 100% of adult cases being financed as out-of-pocket. It is quite notable that the Ugandan government really does a lot to help these patients, as it pays 50% of the out-of-pocket cost, leaving 50% to the household. And while much of this care is subsidized, the residual out-of-pocket costs can be quite high, especially in households with limited resources. And particularly with respect to rheumatic heart disease, we wanted to understand what is the household economic burden of rheumatic heart disease in Uganda. And so let's get some definitions under our belts. All right, so the spectrum of care for rheumatic heart disease can be defined as primary prevention, secondary prevention, and tertiary prevention, with primary being treatment of streptococcal pharyngitis, secondary being treatment of acute rheumatic fever, and tertiary being treatment of acute and chronic rheumatic heart disease itself. In health economics, we also define the spectrum of costs, either from the household, health sector, or societal perspective. We also define the type of costs. They can be either direct medical costs of medications and lab tests, or direct non-medical costs, such as the costs associated with transportation to receive medical care. And then the indirect costs are related to productivity losses due to time spent in illness or time spent as a caretaker. And so we performed a literature review of studies that evaluated the economic burden of rheumatic heart disease. And we only found a handful of primary costing studies that attempted to address this issue. There was only one study which was done in South Africa with the first author, Oye Bamiji. One study which was done in South Africa that looked at the household economic burden of rheumatic heart disease in an RHD endemic region. It is important to note that in South Africa, the financing capabilities are relatively more advanced than in other African nations. So, for example, many lower income patients have access to free public healthcare a lot of the times. And so the direct medical cost they found in this study was $0. And so the cost accrued to the households were the direct non-medical costs and indirect costs. And so we did not feel like we could apply this study broadly to Africa. And specifically, we wanted to understand what is a household economic burden of rheumatic heart disease in Uganda. And so we performed a cross-sectional prevalence-based cost of illness study and looking at 12 months self-reported financial data related to receiving RHD care. The study was done from December 2018 to February 2020, and we used stratified random sample of 87 participants and their households in the Uganda RHD registry. The circles in red are where the patients received the RHD care, the regional centers of excellence where the patients received the RHD care. In Lira in the northern region, in Mbarara in the western region, and then Uganda Heart Institute in Kampala. I will note again that the northern region and western region are more rural than the central region in Kampala. So the outcomes we were interested in were the annual cost for RHD care divided into direct medical, direct non-medical, and indirect costs. And we looked at the prevalence of catastrophic health expenditure, which we define as whether the proportion of total annual direct RHD related expenditure exceeded 10% of total annual household expenditure. And we use a threshold of 10% as a more liberal threshold and a 25% as a more conservative threshold. We also looked at the prevalence of common financial coping mechanisms, such as taking out loans, receiving financial assistance from friends and family, or selling assets. We also looked at which covariates were associated with a household's use of at least one of these coping mechanisms. Our baseline characteristics demonstrate a mean age of 28. Most of the participants were female. And the participants in the more urban central region had higher levels of education, lower household size, higher monthly income per person, and there were only 4 participants who had private health insurance, and all these participants were from the central region. All right, so this figure here lays out the outpatient costs incurred from receiving RHD care. And there were 408 outpatient visits across 87 participants, and the costs are in 2019 US dollars per person per year. We see that the outpatient costs are primarily driven by the cost of transportation and medications, and to a lesser extent, the cost of food and lab tests. Overall, for outpatient costs, it was $57, and $50 of that was out-of-pocket costs. And this is a similar figure looking at inpatient costs. There were 27 inpatient visits across 21 participants. And the inpatient costs are primarily driven by the direct medical costs, and the plurality of direct medical costs come from medications. Overall, the inpatient costs per person per year was $21 for all the regions, and $17 of that were direct out-of-pocket costs. All right, so overall for all the regions for this cohort, we found that the total out-of-pocket cost for receiving RHD care per person per year was $67. And when you compare that to the income and to the household expenditure, this number is quite high. Just imagine spending a month or 2 weeks of your total salary on receiving care for one disease. Then we also looked at catastrophic health expenditure. Using the liberal 10% threshold, 35% of all households had experienced catastrophic health expenditure. Using the more conservative threshold of 25%, 20% of all households experience catastrophic health expenditure. We look at the difference between the more rural northern and western region and compare that to the central region. The northern and western region were 3 to 5 times more likely than the central region to experience catastrophic health expenditure. And here is a utilization of the financial coping strategies. We see that those in the northern and western region were more likely to take out loans or sell assets, while those in the central region were able to receive more financial assistance from friends and family. Looking at the use of one or more of these financial coping strategies, we see that almost half of households had to use 2 or 3 of these coping strategies, and 20% of households use all 3. Again, we see that the northern and western region were more likely to use 2 or 3 coping strategies compared to the central region. And this is our multi-variable model looking at variables that were associated with the utilization of one or more coping strategies. And the only significant association we found was the total direct RHD cost per person per year. And when we look at this result, we see that for every $10 increase in total out-of-pocket RHD costs for receiving care, for every $10 increase, there is a 2.5% increased risk of using at least one or more of those coping strategies. So the take-home point of this project is that many people in Uganda with RHD experience catastrophic health expenditure and utilize financial coping mechanisms. And future reforms should consider limiting out-of-pocket costs for RHD and other chronic diseases. So speaking of future reforms, these results were presented to the Uganda Ministry of Health with a positive reception, and they agreed on the need to address the cost of medication and transportation. And this led to the establishment of 2 programs to decentralize RHD care. The first program used a model where patients could receive their monthly penicillin injections at local clinics rather than traveling all the way to regional referral centers. So right now, the preliminary analysis demonstrates a reduction in out-of-pocket costs and time off work and reduction in transportation costs. The second program was built off of the first program and uses a district-based model where patients have access to all RHD services at 2 out of the approximately 110 district-level hospitals in Uganda. The economic evaluation is pending, and there's collaboration with the Ministry of Health to ensure that there's adequate resources to expand to several more district hospitals in the future. So as it relates to cardiovascular capacity expansion in Uganda, we were also interested in understanding more about the outcomes of patients with rheumatic heart disease and atrial fibrillation, or AFib. So while AFib is the most common arrhythmia seen in rheumatic heart disease, RHD has been systematically excluded from most AFib trials. We do know a lot about the Invictus trial, which was the only large randomized control trial to inform anticoagulation in patients with RHD and AFib. Also, smaller studies have assessed rate and rhythm control strategies for patients with RHD and AFib. Despite these studies being present, there remains a paucity of data to help guide the management of patients with RHD and AFib, specifically in their local context, such as in Uganda. And so we performed a retrospective analysis of the Uganda National RHD Registry from June 2009 to May 2018, and we included patients with clinical RHD. We looked at baseline demographic and clinical characteristics. We looked at anticoagulation prescription rates among those with RHD and AFib. We compared the mortality in those with AFib compared to those without AFib. And we looked at the outcomes along the RHD treatment cascade I previously discussed. And we were interested in which factors were associated with retention and care. So we analyzed a total of, there were a total of 1,530 participants included in the analysis. And comparing those with AFib to those without AFib, we see that those with the average, the median age for those with AFib was 39 compared to 23 in those without AFib. And those with AFib had more severe heart failure, more severe mitral stenosis, and more history of prior stroke compared to those without AFib. And so, as expected, those with AFib were older and had more clinical comorbidities. looking at anticoagulation prescription rates. So I will mention that the anticoagulation used for all patients was warfarin, because in Uganda, the availability of direct-acting oral anticoagulants is limited. And we see that the anticoagulation rates are high, but with plenty of room for optimization, with 79% of patients have been being prescribed anticoagulation, which is in this case is synonymous with warfarin. Over a median follow-up of 203 days, we found an early excess mortality rate of 3%. And the association with atrial fibrillation and early excess mortality was not statistically significant. So when we compared mortality in those with RHD and AFib and those with RHD without AFib, we did not find a significant difference. And this was a surprising finding for us, especially as those with AFib are older with more clinical comorbidities. And this right here is the RHD treatment cascade that we found for this cohort. We define retained as having been seen in clinic at least once within the prior 12 months. And we describe adherent as having taken at least 80% of the prescribed penicillin doses. So overall, we find that the overall retention and cure is very low at 13%. And we also compared the RHD treatment cascade among those with atrial fibrillation and compared that to those without atrial fibrillation. So in those with atrial fibrillation, there is an 18% retention rate compared to a 12% retention rate in those without AFib. So this 6% increase in retention rate was statistically significant. And in the real world, this is also very clinically meaningful. We also looked at the RHD treatment cascade among those with atrial fibrillation who were prescribed anticoagulation and compared those with atrial fibrillation who were not prescribed anticoagulation. We see a retention rate of 13% in those without anticoagulation and retention rate of 19% in those with anticoagulation. And this is also a very important finding, as we have demonstrated that those with AFib with anticoagulation had greater retention and care, and we'll talk about why. And we found that we wanted to look at which variables were associated with retention and care. And the only one we found was, and this is looking at those who had RHD and atrial fibrillation. We looked at which variables were associated with retention and care. And the only one was being prescribed anticoagulation. And we found that the prescription of anticoagulation was associated with an 86% increased odds of being retained in care. And this is an important finding because we have previously demonstrated that within the RHD registry, that those who are retained in care have greater survival. And also those who are retained in care and optimally adherent to penicillin have greater survival. And it's not likely that this benefit was due to penicillin just by itself, but likely had more to do with having more intimate interaction with the healthcare system. We also looked at variables that were associated with reduced retention in care. And we found that the further away you live from an RHD center, then the less likely you are to be retained in care. And those with more severe heart failure were less likely to be retained in care. When we discussed the distance to an RHD care facility, that is just as an important finding as the finding we saw with anticoagulation, because we've said that patients in Uganda with RHD experience high out-of-pocket costs associated with medication and transportation. And so this highlights the importance of the two programs that we had talked about to continue to decentralize RHD care. And so the take-home point from this project are that in the Ugandan context, people with RHD and AFib do not have higher early excess mortality than those with RHD who do not have AFib. And people with RHD who also have AFib are more likely to be retained in care. And we have previously demonstrated a mortality benefit of retention and care. And we showed that being prescribed anticoagulation was strongly associated with being retained in care. And this highlights the importance of programs to decentralize RHD care. All right, so now we will discuss some of the community projects that I am involved in Nigeria. We will move from Uganda in East Africa, and we will go over to Nigeria in West Africa. So Nigeria is the largest and oldest federation in Africa, and it has 36 different states. And let's zoom in on the southeastern part of Nigeria, where my family comes from. We move in to the southeastern Nigeria, and we'll zoom in now to Imo State. Within Imo State, my family comes from Achi, which is a community of about 10,000 people. And Achi is one of the communities in the town of Mberi. Mberi is a town of about 330,000 people. The closest town to that is Owerri, which is a small town of about 1 million people. An eye towards home. So my family immigrated to the United States in 1997. And even though we had established in the US, we still had an eye towards home. And it really just tugged at our hearts to see the early morbidity and mortality due to uncontrolled cardiovascular conditions that in the United States that would otherwise be easily controlled. And so we really wanted to do something about this. And we felt that increasing educational services and access to healthcare in the community would help address some of these issues. So what did we do? We didn't just sit on our hands. We got to work. And we formed Achi Association USA, which is a nonprofit association to help improve the lives of our people in Achi. And it has a mission to provide compassionate, comprehensive, affordable, and accessible care to people of all ages, regardless of economic status in Achimberi and neighboring communities. This is an extended family initiative because not one person can do this alone. It takes a village, literally. And it was founded in 2000, and we're still going strong. We have a number of areas of focus. The ones I will talk about today are related to education and healthcare. So our educational initiative has a couple of different projects. One of them is a primary school project, and the other one is a scholarship project. The primary school was constructed and completed in 2013, and then eventually handed over to the local government for administration. Our scholarship project helps to support secondary school students with their tuition and non-tuition related expenses, so that the cost of education wouldn't be a limitation for them to work towards achieving their dreams. So far, we have sponsored more than 10 secondary school students from the community. So this panel demonstrates a time series of photos of the construction of the primary school in Achi. And you can see the progression from the photos on the top left and all the way down to the bottom right. And this demonstrates the primary school in its completed form with children in the foreground on the top left, and the picture on the bottom left shows a field surrounding the primary school. The pictures on the top right and on the top right and bottom right show the handover ceremony of the primary school to the local government. And I'd like to point out the arrow in the red is my father, Dr. James Opara, and also my uncle Godwin has the arrow with the green. Like I mentioned, this is not a one-man project. It takes a village, and it's an extended family initiative. So we will discuss some of the healthcare initiatives that we are working on. A very important aspect of the work that we do is a medical mission that has been ongoing since 2000, and we're still going strong in 2024. And this is despite the recession of the early 2000s, the great financial crisis, and the COVID pandemic, and the brief recession that came from that. And with the medical mission, what we do is we partner with local nurses and physicians to provide primary care and cardiovascular risk factor modification. And we also provide routine optometry care. A very important part of this mission is that the out-of-pocket cost to patients is $0. And right now, the clinical space that we use is we use a community hall in the community. And we also utilize the primary school building when it's not in use, such as when the children are out on holiday on Christmas. And so this picture was from around Christmas time in December 2018 and shows inside of the primary school building. This is the time where we do the largest medical mission of the year. And this picture on the left shows my father, Dr. James Opara, and I also providing direct clinical care at this time. Within our medical initiatives is also an ongoing medical center building project. So we conducted a community survey to gain insight from the community to have a more formal idea of what their ideas and thoughts are related to their healthcare. And these are the major themes that we saw. A major theme that we saw was that there was a general lack of access to healthcare. And this is despite 2/3 of respondents saying that they had a chronic medical condition that required regular healthcare visits. We also found a major theme that a barrier to receiving that care was the cost of transportation, the time and cost of transportation, and also the cost of the medical services itself. And I mentioned the small town of Owerri. It's where the nearest medical center is. And given the traffic congestion and other infrastructure limitations, the commute to go there for healthcare is 2 to 3 hours. And even once you get there, it's not promised that you're going to receive care because the lines are so long. And so we engaged in the building out of a medical center to bring healthcare directly where people live. And we, as I said, we cannot do this by ourselves. It's not a one-man project. And so we have many partners. And probably the most important partner of them all is the Achi community. They donated the land in which the medical building is being built right now. And then we also bought an additional plot of land adjacent to it to help expand the scope in the future. Not only did the community donate the land, they also cleared the land for us. We also partner with the Walla Walla Rotary Club, which provided the majority of the funds for the construction of the medical building. And we also partner with the local already Rotary Club in Imo State to help provide some local oversight of the medical building project. And currently we have a grant under review with Rotary International to help furnish the medical building with medical equipment. And this panel demonstrates, again, a time series of the construction of the medical building. The picture on the top left shows the community members who are helping to, who helped clear the land. And we see the land and also the frame of the medical building in the background as the foundation is being laid. And then on the picture on the top right, we see the progression of the medical building. And then on the bottom left, we see the completion of the roof The picture on the bottom right, we see paint has been added on and there's now a perimeter fencing for the property. So with Achi Association, we're not here just for the short term to go in and go out. We're here with the community, and we cannot engage in the projects that we do without thinking about sustainability at each and every step. And particularly with the medical center, it's important that we work with community members to make sure that they have input on the medical board and management of the hospital. And also, we will also charge a modest fee to help generate some income. But we have to do this with keeping on the foreground the important cost barrier to receiving care. We'll plan to have a gradual rollout of services. Like I said, we had also purchased an additional plot of land to help expand the services in the future. But we'll roll out our services gradually. And we'll start with primary care and optometry, and then in the future, we'll expand from there. We will have an electronic medical record to help keep track of patients' outcomes and ways to improve the patient care. And also, we have established an endowment fund with a long-term time horizon. So, like I said, we're here for the long term and we're not going anywhere. And we'll also continue to have ongoing philanthropy, and we'll continue to look for future philanthropic partners. So, in conclusion, RHD is associated with excess morbidity and mortality, particularly in younger populations. And while RHD burden has declined in many higher resource parts of the world, it remains endemic in many lower resourced regions. People in Uganda with RHD incur significant out-of-pocket costs related to receiving care for RHD. And opportunities for addressing cardiovascular disease in Africa relate to bringing lower cost healthcare closer to the community. And importantly, Africa has many enthusiastic partners who are committed for the long term to combat cardiovascular disease. My acknowledgements, I would like to thank God, my family, and my Achi community. Especially, I would like to thank my wife, Dr. Hope Opara, for always being at my side at every step and being willing to listen to all my questions and ideas. And importantly, I would like to thank my parents, Dr. James Opara and Mrs. Mercy Opara, for being my best role models in life, my best mentors in life. And like one of my uncles once said, Gawanihi naikfuginazo, and that means proceed forward as we carry you on your back. And this embodies the spirit of the community that I come from. And my other mentors I'd like to acknowledge are David Watkins. I would not be able to be as involved as I am in this project without him. I met with him as an intern at the University of Washington, and he sat me down and we went through a timeline of projects that I was going to do, and it helped me a lot. I'd like to thank Yangfang Su for helping provide mentorship on the costing studies. I'd like to thank Dr. Emi Okello for also being willing to answer a lot of my questions and being a champion for cardiovascular disease in Uganda. And of course, Dr. Chris Longenecker, I need not say more about him. He's always willing to listen and willing to meet. And of course, I'd like to thank Dr. Eugenia Poole for being a champion for cardiovascular disease globally. All right.
Thanks, Chinonso, so much. Let me just thank him for a second on a couple of points when you asked your question. But I want to thank you for your dedication. Also, a nice summary of rheumatic heart disease in Africa. I think it's really important for us to understand the very different epidemiology of this disease. And there might be questions about atrial fibrillation also that I think is interesting, and then your own personal journey and that of your families. Okay. Yes, breathe. You have to share
Thanks, Chairman. So that obviously the research is impressive, but I want to thank you. I'm sure everybody feels the same way for sharing your family's experience and the end part. Can you comment for us who are not, at least I'm not that familiar with cardiovascular disease in Africa? What's the prevalence when you are making the missions in terms of cardiovascular risk factors? How do people treat it? I'm just curious to be educated on that. I'm assuming that treating that is going to be very important and have way more impact than RHD. But can you comment on that?
Yeah, thank you. I'm happy to use whichever microphone, but I can use this one since it's on. Yeah, so when we look at cardiovascular disease in Africa, it's not a monogenous topic. You know, where in East Africa and the more southern parts of Africa, we see a greater burden of rheumatic heart disease. And in Western Africa, we see a greater burden of traditional risk factors. In terms of the burden, that's why we need people to continue to understand the prevalence of rheumatic heart disease, the prevalence of cardiovascular risk factors. Dr. Greg Roth has done a really good job with understanding the global burden of cardiovascular disease in many parts of the world. But there also remains a paucity of data, a paucity of research to really understand what the actual prevalence is. But from my experience, sometimes we go to clinic, it's not uncommon to see people in the community that we serve with blood pressure, with systolics in the 200s. So.
Thank you.
Yeah.
Thank you, Chinonso, for a very good talk, both on your research work, refreshing us the burden of and the prevalence of rheumatic heart disease in resource-limited settings like Africa, and also your community work. As someone who's interested in interventional cardiology and have the aspiration of taking interventional procedures back to where I'm from, do you mind commenting on the differences between, or the advantages or disadvantages of trying to focus on treating the advanced rheumatic heart disease, like building cath labs in resource-limited settings versus focusing on primary and secondary prevention, given that having resources for both is going to be difficult? And I, as someone who's interested in interventional cardiology, it's easy to focus on, treating mitral stenosis with an intervention or doing a surgery on advanced rheumatic heart disease versus focusing on primary and secondary prevention.
Yeah, that's a very good question. I think we need all of the above. I think from an epidemiologic standpoint, we need a lot of primary care and basic access to healthcare. However, we're still going to have people with advanced coronary disease, or people with advanced rheumatic heart disease, or people with AFib that need more advanced procedures. So we need all of the above. So isn't it better for patients to receive that more advanced cath lab care within their country, rather than spending money, spending up their currency to buy resources from an external country from the West, either from the US or America, spending their resources to receive healthcare at a different country when they could be spending their resources within their country to support their infrastructure. So I would say that we need all of the above. And if it's interventional cardiology that you're interested, I'd say just follow your heart and do what you find that is interesting. We do need all of the above, and I think it would be wrong to say we only need to focus on primary care, or we only need to focus on more advanced care. We need all of the above.
Thanks, Chinonso, for an awesome talk. I feel like we all know sort of your infectious enthusiasm for the projects you've been doing over all these years. And I think just to see them all kind of, presented here today, it's spectacular to see, all that your efforts have achieved. My question is related to sort of the implementation of technology in some of the settings that you've been working in, particularly that you mentioned that, retention and care and just more points of contact really help to improve outcomes for patients. And I'm wondering, what are the realities in these communities about being able to do telehealth or telemedicine, or, what kind of access to technology people have, and how that might be implemented in the future to help improve just points of contact and try to improve some of that retention, even and eliminate the costs of transportation and some of the things that these communities highlighted as obstacles.
Yeah, I think that is a very good question. And if I can understand the essence of your question, you're basically, how can we implement the further decentralization of the cardiovascular services, and how do we incorporate technology in doing that?
Exactly.
Right. Okay. So in order to do that, that's why we have to have intimate discussions with those that are providing the care, and listen to what their needs are and what they are capable of doing. I think, and whatever that's done needs to be guided locally by the local context, so that we are not just given instructions from the USA to people in Africa. From a technology standpoint, one thing I will say is the use of handheld ultrasonography. It's really played an important role in the decentralization of care. Rather than buying an ultrasound machine that's cost as much as, a small car, you can spend a quarter as much money to buy several more handheld ultrasound machines that you can distribute to local clinics.
Great. Thank you so much.
Okay.
Yeah.
So I think that's an interesting idea of the telehealth. I've had the opportunity to be involved in a project in Vietnam in which their heart failure clinic, they have a heart failure clinic, has now adopted a telehealth model in which they basically have a physician on the other end of the line, do regular check-ins, and they're actually, we have a paper coming out sort of exploring how this actually is working. The biggest problem is that the control group is the one that's being seen in the heart failure clinic pretty regularly. And so there's not a huge difference, of course. But in something like this, if you could leverage cell phone technology to kind of, I think this is what you're getting at, Lee, of at least the check-ins and the follow-ups and the reminders and all of these things that could actually be done. I think it's a little bit more straightforward in heart failure care, obviously, and Vietnam has sort of a better infrastructure, I would imagine. But it seems like that might help at least with some of the retention rates that you're showing that are so low. But I don't know, what is the cell phone sort of prevalence in that area of Nigeria?
Yeah, so everyone has a cell phone. It may not be an iPhone or something like that, but everyone has a cell phone that they can use, and that's also why we're working to roll out an electronic medical health record. We may even have the possibility of consulting with people outside, for example, to take a look at some results there. But I think we'll have to start gradually too, because these services do cost money, both to the patients and from the health sector perspective too. But we plan to at least start with the electronic medical record as a way to digitize things and then proceed forward from there.
Yeah, it makes a lot of sense. The other thing that the American Society of Echo Society did now many years ago is actually to collect ultrasound data, the echo data, and upload it to the cloud. And there were, I can't remember how many, about 100 of us worldwide who actually interpreted these studies real time or nearly real time, and then generated reports for the people to use that. So I do think there's a lot of opportunities to do that, but it is marshaling resources, and there is certainly a cost, no matter how cheap we think things are getting now.
Definitely. Yeah, thank you for your question.
Chinonso, thank you so much for sharing all of that. That was really cool and really impressive. My question is what's the, I think you did a really good job of showing what the cost burden is. And when it was like $27, I was like, crap, I'll give you $27 right now. But in that same vein, when you zoomed in on where your where your community is in Nigeria, it's like, oh wow, this is huge. What's the pattern that you've seen of Western philanthropy and the role in that? I mean, is it increasing? I would imagine that research projects like yours only develop awareness around this, and I would hope that it was kind of increasing in frequency. Have you seen any patterns over the years?
So to understand your question, looking at what are the patterns, are you talking more of are we having more philanthropy from the Western part of the world, or is there being more recognition of cardiovascular disease in Africa?
Yeah, I think the recognition is growing thanks to projects like yours. I mean, is that leading people to invest more money? People that have money?
That's a good question. Anecdotally, we've been partnering with the Rotary Club, and now we'll see, we have a grant going out to the Rotary International. And we've, just like in Uganda, there's been a growing list of funding partners and supporting partners. So anecdotally, from my perspective, I feel like it's growing. Yeah,
It's perfect. Thanks.
I think we have to stop. You want me to stop? Yeah, okay. It is 7:30, so any further questions, you can come on up to the podium afterwards, but I want to thank everybody who is on Zoom watching and here present in person today. And thank you so much, Chinonso, for this great presentation today.